Quervain syndrome. Quervain syndrome is stenosing tenosynovitis of the first dorsal compartment of the wrist. It's more common in the dominant wrist. It affects the first dorsal extensor compartment of the wrist, which contains the abductor pollicis longus and the extensor pollicis brevis. They have variable anatomy, with the abductor pollicis longus having multiple slabs and the extensor pollicis brevis have its own compartment. The extensor pollicis brevis is more dorsal than the abductor pollicis longus. Remember, this is the boundaries of the snuff box of the wrist. Remember, in the second compartment, there are the two tendons of the extensor carpi-radialis longus and extensor carpi-radialis brevis. The first compartment causes Quervain syndrome. The relationship between the first compartment and the second compartment causes intersection syndrome. And the third compartment will contain the extensor pollicis longus. In Quervain syndrome, there will be pain and swelling over the radial side, the thumb side of the wrist. Pain is usually located at the base of the thumb and to the side of the wrist. It occurs due to inflammation, thickening, and stenosis of the synovial sheath. The condition is more common in women, and the patient will complain of pain with movement of the wrist as well as swelling with tenderness over the styloid process of the radius. Activities that may cause Quervain syndrome include twisting, wringing out wet towels, hammering, skiing, racket sports, playing the piano, lifting heavy objects. The condition may also occur postpartum or post-traumatic. Differential diagnosis: CMC joint arthritis, arthritis of the basal joint or thumb CMC, carpometacarpal joint. Another differential diagnosis is the intersection syndrome. Pain is felt on top of the forearm where the two muscles, the abductor pollicis longus and the extensor pollicis brevis, cross over the underlying wrist tendons, the extensor carpi-radialis longus and brevis. In this case, the pain is located about 4 cm from the wrist joint. Another differential diagnosis is Wartenberg's syndrome, which is compression of the superficial branch of the radian nerve. The pain is located about 8 cm proximal to the radial styloid. In this syndrome, there will be pain and paresthesia on the dorsum of the hand with positive Tinel sign. It is hard to differentiate between Quervain syndrome and basal thumb arthritis. You do the Finkelstein test in Quervain syndrome and you do the grind test for basal thumb arthritis. How do you do the Finkelstein test, the test used for Quervain syndrome? The test is conducted by having the patient make a fist with the fingers closed over the thumb and the wrist is bent towards the little finger, ulnarly deviated. The hand is pulled so that the involved tendons are stretched, causing sharp local pain if injury and inflammation is present. Warn the patient before you do that test. Tell them what they should expect. This test may be very painful if the tendons are badly inflamed. How about the grind test for the basal thumb arthritis? By axial loading, pushing and rotating the thumb metacarpal bone, Grinding may be felt within the joint. Pain will be located on the volar aspect of the wrist. X-ray is really not indicated. However, it is advisable to get an X-ray of the hand to rule out basal thumb arthritis, which may coexist with Quervain or may be the primary problem in the patient condition. Treatment. Conservative treatment. Rest, non-steroidal anti-inflammatory medication, thumb spica splint, steroid injection. You treat it first with non-steroidal anti-inflammatory medications and immobilization with the thumb spica splint. And if that doesn't work, then you try steroid injection into the first dorsal compartment. Most cases improve with non-operative treatment. You will do surgical release of the first dorsal compartment after failure of non-operative treatment for 6 months. Recurrence of the pain and inflammation may occur after surgery. Steroid injection. Inject steroids into the tendon sheath of the first dorsal compartment with the rest over a rolled up towel. Surgery. Surgical release of the first dorsal compartment of the wrist. Make the incision in the dorsal aspect of the wrist. Protect the radial sensory nerve. The abductor pollicis longus and extensor pollicis brevis tendons are freed from the surrounding retinaculum and tendon sheath. Complete decompression of the first dorsal compartment includes any additional slips and additional compartments. The tendons may have separate compartments, and each compartment should be identified and released. Pain may occur after surgery due to neuroma, inadequate decompression and release of the tendons, or instability and scarring of the tendons. Thank you very much. I hope that was helpful.